Welcome, everybody. Nobody brings lunch and no lunch. Okay. Well, you don't need it because this is going to be a fantastic discussion. So I've been asked to introduce our new colleague here and my new colleague. But what's really interesting about Dr. Sinnott is the path that he took to get to Miami. And I think for students here, it's an interesting one. So right now, you're an assistant professor in the Department of Kinesiology and Sports Sciences. He completed his athletic training from a college of the Siskiyous, which is in California, near the Oregon border. Okay, has anyone been there? Rural, a lot of rural land around there. Okay. He got his BS from Sacramento State University and his MS in exercise science from Cal Poly, Humboldt, and his doctoral degree in rehab science from the University of Pittsburgh. So this is how I learned about Aaron from the University of Pittsburgh, and we're going to continue his story. Before pursuing his doctoral degree, he was a site coordinator for the NCAA DoD Care Consortium. So for people who don't know what that is, that was a very important group of colleges around the country that have big athletic departments and see a lot of athletes that do sports, working with the Department of Defense. And there was a lot of dollars put forward for this consortium, and they just had their annual conference, which was like very interesting. They're doing some incredible work. So student athletes from the NCAA and military academy cadets mixed together, looking at their data, and he was responsible for implementing baseline and post-concussion clinical assessments for 450 athletes at Cal Poly. So that was like your first intro into this whole concussion world, right? Okay. After that, he was a postdoc at the Feller Center at the University of North Carolina at Chapel Hill, where he further developed skills to measure head impact biomechanics in American football, alongside engineers, biostatisticians, and epidemiologists across 8 different institutions. He contributed to a multi-site study observing head impacts via instrumented mouth guards with the varsity football team, which is very interested in itself, which was all the sensor information, which we sort of kind of did here when we had a race car driver doc, Dr. Olvey, looking at sensor information, but we found there were a lot of issues putting them in helmets, putting them in ears with the sweat and the movement and the artifacts. So I'm sure you learned a lot from that opportunity. During his doctoral training at University of Pittsburgh, he collaborated with neuropsychologists, physical therapists, and athletic trainers, and he developed and standardized clinical exercise assessments for concussion. So I think we know about that, and I definitely know about that. He also, over a decade of clinical research in concussion, has developed his own ability and his own ideas now, which really brought him to the University of Miami. So his research interests really include aerobic exercise on neurocognitive, vestibular, ocular, and somatosensory function across post-concussion milestones. He also looks at improving the return to play decision-making with the use of standardized exercise testing for athletes, recreationally active individuals, just not for sports athletes. And he's taken all this now to here, to the University of Miami, where with the University of Miami and the things that we have to offer here, he's going to be working with physical therapy, the athletic trainers, and our team. So we have a multidisciplinary team of him looking at what he's going to be talking about today, which is looking at evaluating the readiness of these players, and he's going to explain how he's going to do this. But I want to say one more thing about Dr. Sinnott. Tonight, he is receiving a Vice Provost for Research Award. So there you go. That's his journey. He hasn't only, how many months have you been here? since August, and there you go. So congratulations, Aaron, and welcome to the Miami Project, and come on up and let's hear all the great things you want to talk about.
I will be mindful of time, and fortunately for this, I don't have any disclosures, so this is a short slide. I do want to be sure to acknowledge the large teams that I've been collaborating with for the last decade or so. Dr. Ortega at the lower right, he was my advisor at Cal Poly Humboldt. We were instrumental in further understanding preseason baseline neurocognitive functioning with our high school athletes in the Northern California community there. The left picture here is actually from my doctoral studies. I was split between two different labs. There was the Concussion Research Lab at the University of Pittsburgh Medical Center. There's also the lower left here includes the Neuromuscular Research Laboratory at the University of Pittsburgh as well. In the lab at the lower left, we primarily worked on human performance optimization strategies for military personnel. We had access to sophisticated equipment that we were then able to then apply to a clinical setting with the University of Pittsburgh Medical Center for their concussion patients. And then at the upper right, that's from the Gefeller Center. Matthew Gefeller unfortunately passed away in 2008. He was a high school athlete who had sustained a head injury in his sport, and then upon a premature return back to sport, he unfortunately succumbed to those injuries. And so in 2008, or actually 2009, the research lab that was named after him has primarily been interested in the effects of concussion, not just with acute concussion, but also repetitive head impact exposure, and then also a new fold now with military personnel and what this might mean for service members returning back from combat. And so to keep in line with the overall title, I will have one brief tangent. We'll go over more recent work that I did during my postdoctoral training. But then keeping in line with the title, we'll have a chance to describe the dynamic exertion test that we use to then evaluate physical readiness to return back to sport following concussion. And then also physiological recovery. And this is the title of the Provost Award that we'll be doing for this upcoming year. And it's intended to then really within the study design and this framework allow us to then conduct a prospective study of head impact burden with our high school and college athletes. And then this will be useful to then further informing larger investigations to look at more sophisticated measures of autonomic nervous system function. So from my work at University of North Carolina at Chapel Hill, I was very fortunate to be a part of a multi-site study where we were using instrumented mouthpieces. As you can see here in the middle frame is an instrumented mouthpiece that has an accelerometer and a gyroscope, so we could record head impact, not just the occurrence, but other metrics of linear and rotational acceleration. And I've been able to contribute to some work where we're able to identify head impact burden as associated with physical load burden in some of our college football athletes. These are individuals that might be wearing GPS monitoring devices during their practice and games. And so I have interest in being able to then merge different types of data streams so that we can then better understand participation in sport. And especially with concussion, we do find that those individuals that engage in more participation immediately following a suspected concussion, they actually have longer recoveries. And there's a lot of interest about the continued participation and activity immediately following a concussion. I believe we could use instrumented mouthpieces and even GPS tracking devices to then have a more objective approach of measuring physical activity immediately following a suspected concussion injury. Fantastic. Yeah, excellent point. I'm glad you bring that up. One of the items that had been of interest from our consortium was around the soft shell padding that's commonly recommended in football, American football, and many folks have seen the Guardian cap, especially at the NFL level. The NFL has a mandate for several position groups, actually most position groups, to wear a Guardian cap over the course of a season. It's been suggested to reduce head impact severity in football players. However, there is some disagreement between some of the research and what we find between research that's conducted in the lab, where we have a little bit more control over some of the aspects of head injuries or head impact sustained in football. Those are in disagreement with some of the more field-based studies where we're able to use some of our head impact monitoring equipment out in the field. And so in particular, there are some studies that, for instance here, those vertical bars, those are actually indicating the percentage of reduction of head impact severity of various locations of a football helmet for various types of football helmets. And so that's of interest for my field in biomechanics to then try to understand helmet location and also the protective equipment capabilities to then reduce head impact severity. However, there are several very small sample sizes for some of these other studies using field-based data that show that there's actually no difference between linear rotational accelerations when you look at these individuals that may be wearing a guarding cap compared to those individuals that might not be wearing a guarding cap. We had a preseason analysis where we were able to examine 5 offensive and defensive linemen athletes, compare them to offensive and defensive linemen that may be or may not be wearing a guarding cap, and we had observed no differences in head impact severity. However, we wanted to then extend this across the entire competitive season, and so this work is currently under review. It was presented at the National Athletic Training Association last summer, and from this work, we're able to then observe the original 10 from this initial sample, and then able to then observe their head impacts over the course of an entire season. And so the instrumentation for the guarding cap includes it's a dual layer soft shell padding with primarily foam components. And this is our head impact telemetry system. It's a different type of sensors. There's a plethora of research with the helmet-based sensors, and we're able to then use this for this type of analysis. Right here, just giving a general overview of the number of impacts that we're able to collect from the sample. One thing that was important about this particular study is that we were individually recording every one of these impacts and then video confirming every impact. And so we're able to then only use true video confirmed impacts into the final analyses. After we kicked out, let's say, helmet-only practices, shoulder pad initiated events, and really focus on helmet-initiated impacts to then really understand if a guarding and cap pad might reduce linear or rotational accelerations. For some of you that are in your academic training, I will just kind of convey to the group that statistical analyses approaches, they are certainly advancing in the last number of years. For concussion, we have typically used parametric stats, so let's say t-tests and NOVAs, but they don't necessarily have the individualized responses, especially if you want to look at recoveries over time. And we use that type of a model here where we're able to use a linear mixed model approach, where we want to observe relationships between factors such as their position group, let's say the helmet location, and even the play type, if it was a running play or a passing play, and then use all those factors in a model to then examine head impact severity. These are the general descriptive results as far as median and interquartile ranges for linear and rotational accelerations. But to really interpret the model and the model fit, we are then able to then identify several relationships with linear and rotational accelerations. For instance, amongst position groups, we found that offensive players had greater rotational accelerations than defensive players. Also, compared to individual drills, rush, inside run, and 1v1 drills actually had greater rotational accelerations. And also, we found differences in head impact severity for both linear and rotational outcomes. Importantly, though, within this modeling framework, guarding cap had no difference it had no role in the relationship for linear or rotational accelerations amongst the sample. And so much of this work is really understanding the lessons learned from conducting head impact biomechanics research to then really apply it to what we would be able to then conduct with new projects here at the University of Miami. From the University of Pittsburgh and much of my training I was able to complete there. Much of this work is around a clinical profile-based approach for how we are then able to better evaluate and treat concussion injuries. And it'll typically present as some type of injury, and there's some type of individualized symptoms and impairments that we might be able to observe from concussion. The 2 papers at the right, those are actually my first 2 first author publications. The one in the upper right was actually from some of the data we collected at Cal Poly Humboldt. We were able to observe amongst a large cohort amongst our high school and collegiate athletes that for those individuals that were reporting symptoms, maybe even prior to the season, before an injury had occurred, those symptoms that were reported were actually linked to some of their impairments following a concussion injury. And so it adds to the value of understanding from a comprehensive evaluation of pre-injury factors, comorbid factors as well, might be able to give you a better clinical insight for how a patient might be presenting. A key aspect about this is that by identifying symptoms and impairments, concussions are now coalescing into various subtypes of the injury. And importantly, for where our field is moving, is that concussion is no longer an identified injury that's just diagnosed and then allowed to just sit idle and then allow an athlete to then progressively recover. These are now active and targeted injury or interventions that we're now applying to concussion to help hasten recovery. And just kind of a brief overview from the University of Pittsburgh model, what we see is that a combination of various domains that as part of a clinical evaluation might be able to then give a clinician insights into a particular subtype or profile that those patients might present in. And for instance, individuals that might present with a vestibular type impairment, they might be individuals that might have greater benefits from being assigned a targeted vestibular type of intervention. In particular, for my area of interest, really evolves around physical exertion. And many clinicians are challenged with determining if an athlete is physically ready to then return back to sport following their concussion injury. International recommendations for concussion have acknowledged that some type of progressive stepwise return back to sport is advocated, and it's something that would be beneficial for most athletes returning to sport. However, even though there have been some clarifications to this model, such as more specificity within stage 2 to increasing heart rate to a certain percentage of age estimated max, this type of model and this protocol, it does have several limitations, and primarily this has been standard of care since 2008. And there hasn't been much evidence to support this model and this framework. And in fact, it actually restricts many clinicians to abiding by a very strict protocol where, in fact, much of the evidence that, especially in the last 15 years, has identified that concussion can be evaluated with a series of more objective evaluations. But when we look at return to sport, there are certain limitations as it applies to this model. Primarily, progression through the return back to sport progression is based on symptoms. Symptoms are important. We need to account for them for clinical decision making, but they aren't necessarily the sole component for progression to them returning back to sport. It's also not necessarily objective in that protocol as well, and also doesn't necessarily reflect some of the recovery timelines that we might see with various subtypes of concussion. And so working with other clinicians, we felt like there was a need to then have some type of objective physical exertion evaluation that's going to replicate sport movement, be clinically feasible, and of course have the objective components. And so with Dr. Kochik and some of the other clinicians at UPMC, we had developed the dynamic exertion test. It's a 30-minute exertion evaluation to help inform if athletes are physically ready to then return back to sport following a concussion. There are two parts to it. There's an aerobic and a dynamic movement component. The aerobic component is simply a 12-minute treadmill protocol that we had then based on normative values for cardiorespiratory fitness for adolescent and adult athletes. And so by using American College of Sports Medicine's running equation, we're able to then identify a particular protocol to run on a treadmill, where we'll then ask athletes to then run for 2 minutes at a low speed, like a warm-up, and then from there they engage in 10 alternating high and moderate speed running speeds on the treadmill. For instance, males will run between 5.5 and 8.5 miles per hour, and then females would run between 4.5 and 7.0 miles per hour. And so in total, it's a 12-minute protocol. Primary goal is to then have individuals then attain an exercise intensity that would then be useful for the next step of the exit, which is a dynamic movement component. And there are these functional tasks and also the change in direction tasks. The functional tasks are primarily selected as a series of movements that are provocative in nature. Many clinicians identify the vestibular system can be provoked by some type of dynamic movements. And so what we've incorporated here is a simple circuit, 10 repetitions of either squat jumps, side-to-side push-ups, or these medicine ball rotations. And then after 3 cycles of the dynamic circuit, there's a ball toss task where we then ask individuals jump, turn left or right. And as they jump, turn in a direction, we toss them the ball, and then from there they toss it back. Both of these tasks are simply just intended to be functional maneuvers and to see if they might be provocative of concussion-type symptoms after completing the treadmill protocol. The next series of tasks are the change in direction tasks. We demonstrate these tasks. We're actually doing a video demonstration now, so we'll have a video demonstration of each of the tasks. An individual will complete 2 trials of each change in direction tasks, and each of these are recorded for hand time. This slide will get a little busy, I will warn you now. Actually, none of these are playing. There's a box drill shuffle. Sprint, side shuffle, back pedal, side shuffle back to the beginning. They'll do 2 cycles of that. There's also the box drill karaoke. After 30 seconds, they'll do another trial of the box drill karaoke. The zigzag drill is where I have a little bit more interest in some of these tasks, where we now increase a little bit more of the head-body movements to try to provoke as much vestibular and ocular perturbations in addition to the the physical exertion intensity. There's a modified pro agility tasks. Each of the cones are placed 2.5 meters apart from each other. We want to create a test that could fit into many orthopedic clinics. And then the final task here is aero agility. We're presenting a card, and on the card there's a block, and the block corresponds with a cone either to the left or to the right of that individual. I present a card, they then turn, run, touch the cone, return back to the middle. I'll then display a next card, and we would repeat 16 of these instances where I have just the block. And then on the next 16, I'll inform them that regardless of where the block is, go in the direction of the arrow, so you have an congruent and incongruent scenarios. Everything's recorded onto on a standard report sheet, and so then we're able to collect heart rate throughout the task. We collect blood pressure pre and post exercise, but because we also do collect heart rate throughout each task, we do have our heart rate as an overall outcome. And there's also more objective tasks related towards performance. So we do have change in direction completion time. Errors are instances if they knock over a cone with it, or maybe not touching a cone when they're instructed to do so. And then also to keeping in mind of best practices for concussion and clinical evaluation, we do incorporate symptoms and rating of perceived exertion. There are 3 papers that were evolved from my dissertation work, and the first one was being able to then better identify the stability of the measures and the outcomes. And so I was able to enroll 92 individuals into this particular study. 79 of these individuals were able to complete a second visit, approximately 7 to 10 days after the first visit. And amongst that 79 that completed the 2 visits with complete data, we're able to identify a couple of key outcomes, primarily the heart rate outcomes throughout and were fairly stable. In addition to the MDCs, which are at the right-hand side, the MDC is a minimal detectable change cutoff, and that's where I have a lot of interest for what this might mean for clinicians. The exit test is a fairly generalizable assessment that doesn't require sophisticated equipment or technologies, but in order for it to be clinically intuitive and useful for many providers that might be out in rural settings, the minimal detectable change allows a clinician to be more confident in what a change of performance might mean. And if someone might be underperforming, the minimal detectable change allows you then have a more objective interpretation of maybe a faulty performance for that particular individual. For the second manuscript, we were able to then compare various subgroups, so age, sex, body mass index, and sport types. We observed that some symptoms were differentially reported between some of these subgroups, and it was similar to what we have commonly seen in the field. And so even though there's a widespread performance similarity between many of our individuals, because many of these folks are healthy, there are some outcomes that might be important to then consider, maybe male and female differences, or maybe aspects that would differ between adolescents versus adults. For the third manuscript, and this is somewhat of a transition to some of the work that we'll be doing here, and as it applies to autonomic nervous system functioning, in particular for heart rate variability being a proxy measure for this, there is some emerging evidence in the field to suggest that autonomic nervous system functioning may still persist after some athletes might have already returned back to sport. And so that presents a significant concern for many healthcare providers that want to ensure that their athletes are physiologically recovered before returning back to sport. And so for some of the early studies that have been conducted with heart rate variability, whether it's a cold pressor test, some type of physical exertion, we observe that heart rate variability or some of these autonomic nervous system outcomes, they are similar pre-exercise, but they're going to be different after some type of stressor. And so that's what this work entailed. We wanted to then examine potential similarities or differences between 23 of our healthy athletes that we were able to bring in for the dissertation study, and we matched them by sport, age, and sex with patients that were returning back to sport from their concussion. Most of our outcomes for the exit test as a physical exertion battery, many of those outcomes were similar, as we would expect, but we also were able to observe some differences post-exertion, which then builds upon some of these other studies that are suggesting that we could use exertion as some type of stressor to then evaluate potential persistent dysfunction to the autonomic nervous system. There's a brief 2-3 slide as far as some of these advancements that we're doing with exit as applies to dynamic exertion. I'll just skip to the second highlighted item here. We've been able to then identify with the use of these minimal detectable change score outcomes how some patients might have endorsed, let's say, motion sickness history, migraine history, Some of these other factors that clinicians use to then interpret neurocognitive performance, but also how those factors might influence their performance on the exit test. What we would envision is a holistic incorporation of these exit outcomes with some of the information that many clinicians are already collecting as part of their standard care. Yeah. For the primary dynamic exertion test, we do these. This would be as they completed most of their recovery and they're doing their interventions, and this is at their medical clearance to then return back to sport. And so, yes, and so in agreement, certainly. And so one of the goals of the exit test is to find individuals that might be under endorsing symptoms, and we're trying to, in an effort, provoke the vestibular system. The exit test is what we would envision as a broad screening tool to then be used to inform if athletes should be medically cleared to then return back to sport. Up until this point, some athletes or non-athletes would be expected to have symptoms that might be provoked with exertion. The next slide is actually on the types of exertion, which I have a lot of interest in as well. Because there are some aspects of exertion, in particular ones that might include the vestibular system, that might give a clinician more input for the types of impairments post-concussion. Yeah, excellent point. And as I mentioned, the exit, this is primarily for individuals that are on the cusp of being medically cleared to return to sport. They should have completed various aspects of their own interventions that will be tailored towards their own impairments. Yep. Yeah, excellent question. I have not met him yet in person, but he's actually on a slide that we have for representing our team. Yeah. Yep. Yep. Yeah, certainly. Excellent questions. And I think even for both my interest in cardiorespiratory fitness and physical capabilities as well definitely has a role to play for the progressive nature of the test. So for your first question, it is a progressive test in nature. We do that 12-minute exertion. We really try to have the goal of increasing their heart rate to a particular point. With the first dissertation manuscript, the heart rate responses immediately following that 12-minute protocol were similar between visits 1 and 2. So the goal is actually from the 12-minute protocol, when you finish the 12 minutes between visit 1 and visit 2, we're fairly confident that you'd have a similar heart rate. However, in agreement, the remaining components, there is a progressive nature of you're adding more tasks. And that's actually of interest for many clinicians that are trying to also tease apart what is concussion symptoms that might be endorsed from their concussion and what are concussion symptoms that might be endorsed from physical fatigue and deconditioning, because we do see that as well. Some of these concussion symptoms, they're non-specific to the injury itself. And so if there's a physical exertion assessment, that might be able to then provide a clinician better granularity for what might be physical deconditioning, as well as informing if they are truly ready to return back to sport. Part of that is they should be conditioned. They should also have no symptoms with provocative maneuvers. They should also have neurocognitive functioning back to their pre-injury levels if you have a baseline. All of those components are a part of the physical readiness medical clearance evaluation. And so to Dr. Dietrich's point, right, we would want to have a complementary assessment that should hopefully be able to provoke symptoms regardless of which type of sport you might be able to then be derived from. One thing we have seen, though, for the type of tasks in specific, some of our data, we brought in hockey athletes, right? Hockey is a very different sport than even American football or soccer or basketball. And so we believe that those are accepted limitations for the way the structure of the assessment is currently set up. But in an effort to make something that's much more generalizable that many clinicians could use on a widespread scale, there are some benefits that we're able to then apply to that model as well. And I think to the bigger point here is that's where I think we need the data, and that's something that we're proposing as well with this test too. Yeah, yeah. There are a couple of other clinics, some other fellows from the University of Pittsburgh Medical Center. They've gone on elsewhere after Pittsburgh, and so some of their physical therapists and athletic trainers nearby or at those particular clinics are starting to use the exit as well. But one of the important challenges that we have right now in the field is understanding what a clinical cutoff might be for a various sport type or various maybe more elite athletes even within a particular sport type. Those are all questions that we have interest in. Additionally, for University of Pittsburgh Medical Center, they do have a satellite region community with, this is Ireland, for some that did not ace geography. But there are a number of actual hospitals that are within the UPMC medical system. And so there are other folks here within the system that are doing the exit tests on Gaelic football and other sports that we don't typically have as common here in the US. And so really kind of addressing the topic that was actually brought up here, there's a lot of interest for the types and the modes of exercise in of itself. And so much of the work that was inspirational for the exit test is if we can do an exertion test that's going to be more provocative of the vestibular system, does that give you more specificity to some of the impairments from concussion? And in particular, there's a study cited here from Popovich where there were 46 of these asymptomatic patients. These are athletes that are claiming that they are feeling better, they're returning back to sport, and they're hopeful to then have at some point a medical clearance to then return back to sport. All 46 of these individuals completed some type of structured exertion in their clinic, not standardized to what we have done with exit, but this was just an observed protocol that their clinician would then administer. The initial 11 had symptom provocation during aerobic exercise. And this was all, for all these patients, they all did the aerobic, and then they did the more dynamic exertion. And so there were an additional 17 patients that did not have symptom provocation during the aerobic exercise, but then they had symptom worsening during the more dynamic forms of exercise. A key part of this, though, is that are we talking more about maybe exertion duration and not necessarily the type of exertion, because it wasn't necessarily controlled for here. And this is what I use as inspiration for a proposal that was funded by the American College of Sports Medicine. It was given the Clinical Sports Medicine Endowment Award, which is a recognition that some of these outcomes we would hopeful that would be beneficial for many clinicians and have a readily impactful outcome for many clinicians. Unfortunately, this was my project that was cut short due to COVID. And this was right in spring of 2020. We were able to then make several advancements with it, but I don't have as much of the clinical data set to present. But here's what I created. We started out with the series of cones, but now we expanded it in such a way that I'm presenting a card now with 5 circles. One of the circles is shaded in. And we're presenting these cards in such a way that an individual is instructed to walk, touch a cone, return back to the middle. And we have this in synchronization with a metronome. And now can we control the pace and the intensity, but then now we're doing more of the head-body movements in a more controlled task. And so as this person is doing the task here, on the other iPad, I'm presenting actually a secondary cognitive task where we have Stroop and a flanker task. I'm presenting either the color or the arrows. So as an individual's going through this exertion task, they're also doing a secondary cognitive task. The Buffalo Concussion Treadmill Test is the most commonly used test for concussion. And it's fairly simple on a treadmill, starting with 0% incline. There's a set speed based on your height. And then each minute, the incline would then increase 1%. After 15%, then the speed will then continue to increase. And so it's all done on a treadmill. It's isolated, considered more of a uniplanar type exercise. We had interest in doing something a little bit more dynamic. The challenge, though, is seeing if there's a way that we can control this in such a way that we can have similar heart rate responses. This data here I'm presenting is from the 28 healthy athletes or healthy individuals that we're able to enroll. That include 14 male, 14 female. And we observed that we observed that heart rate at the completion of either one of those protocols was similar. There were some differences that you could see towards the midpoint of the protocol. And overall, though, these symptoms that were reported between the two were fairly similar. The next goal out of this particular project was then have a sample that was going to be matched with our healthy controls that would then complete the same assessment post-concussion. Whether they do the dynamic or the aerobic, if there would be a difference in symptoms, we have a lot of particular interest in. And so I present some of this work as kind of like, here's the transition point to really what we're doing forward. I'm in the Max Orbitz laboratory building over on main campus, and there's a picture of the Lennar Center in Coral Gables as well. I do also want to give a shout out to many of the team members that we have with the UHealth Concussion Program. And so, yep, Dr. Hotz is here and Dr. Hoffer as well. Many of our team members are included here. I did want to give a shout out to Raymond, even though he's not particularly on the team anymore. He had recently left. I believe he's finishing up his clinical training, physical therapy, and so he's off to do amazing things. But a key interest point for me to then come here to join this team was that they were able to set up a framework, and over a decade of working with the community and the athletes in this region to then instill a baseline testing program, and to then also set up a network of clinicians that could then improve how we manage concussions. Oh, you know what? I apologize for that. Yeah, that's Dr. Solano. It is. You think you caught me. I copied the text and I didn't change the name. Got it. Yeah, that stays here in the room, and for those on Zoom, yeah. And so, you know, in coordination with this team that we're able to do here with some of this work at University of Miami, this initial goal is to really set out and do more of a normative data set of what we're able to do with our club sports team. And so one of the studies that we have that will be up and coming this next year is that we'll be doing the exit assessment amongst a number of different club sports. These club sports at the right-hand side, those are all required to then take a pre-injury neurocognitive assessment, the impact test, as part of their participation. And so we'll be leveraging this already in place baseline testing program to then also incorporate this physical exertion battery that would be useful for their clinicians if they choose to use it. But we're also building out the larger data set that would then be able to then allow us to inform performance cutoffs that would be for each of those particular subgroups. And really the final topic here, as it applies to sport-related concussion, is looking at the physiological recovery. Up to this point, we looked at physical readiness as an evaluation approach to return to sport post-concussion. But autonomic nervous system dysfunction, we had explored a little bit of that with my final chapter from my dissertation, but there are important considerations, especially as you look at healthy athletes that might be participating in contact and collision sports, and those individuals that might be experiencing a diagnosed concussion. And so in this overall project, I want to evaluate both repetitive head impact exposure and clinically diagnosed concussion in a prospective study of autonomic nervous system dysfunction. And excitingly, this is the award that we recently received that we're excited to embark on this work. As I mentioned, I believe this is a framework within the study design that we could then add in new measures, and we can incorporate something that's a little bit more multidisciplinary even within its current framework. Overall gaps to be addressed: does one season of head impact exposure affect autonomic nervous system dysfunction? Will clinically diagnosed concussion exhibit ANS dysfunction as we compare them to healthy controls? But also, how do these other lifestyle factors that we have seen affect autonomic nervous system functioning even amongst the general population, how do these other factors relate to our interpretation of autonomic nervous system functioning amongst patients? And so overall within this particular type of study, we have interest in coalescing all these particular factors and then better inform if autonomic nervous system functioning or aspects of proxy measures of ANS functioning might be important for evaluating concussion impairments. And so for this particular study, we'll be enrolling in collision sport athletes. That could be from football, ice hockey, rugby, lacrosse. The reason why I've selected these sports in particular is that their sports require the use of a mouthguard for safe participation. And so for the future grants I'm already submitting to, we're taking the work that we did from my postdoctoral work, and can we deploy mouthpieces to now on a scale of not just one football team, but now 6 different teams where we can then now better understand potential sex similarities and differences as it might be related to head impact exposure between those sports. We'll also include non-contact sport athletes, and so these are individuals that don't typically have direct impacts in their sport involvement. There'll also be a matched design to this as well, so there will be patients that are being treated by the UHealth Concussion Program, 20 individuals that will be evaluated at some point during the return to sport progression. They've already completed some exercise, but they aren't quite yet medically cleared to return back to sport. And then the healthy controls will be matched by sport age and sex. For the visits, the collision and non-contact sport athletes, they'll be completing 2 visits, one preseason and one postseason. And then the concussion control groups will be completing one visit. All participants complete the same procedures. They'll do a series of questionnaires around the lifestyle factors and whatnot, demographics and things. Then they'll go through a physiological monitoring period where we'll do a CETA measurements, and they'll also go through supine and standing, which are part of clinical practice recommendations for concussion. They'll do that 12-minute protocol on the treadmill that was already established from the dissertation work. But then we're now going to do post-exertion measurements of their ANS functioning. So instead of the overall 30-minute where we might have things such as, so the points that you had brought up, if we were looking at a subtle measure of ANS functioning, can we control the intensity and the overall duration? Where 12 minutes we had seen has fairly stable reproducibility of heart rate responses. When we do the full 30-minute, there are a lot of other factors that go in with it, additional rest or things. So for this particular question, let's look at 12 minutes where we know we can have stability in heart rate responses, and then look at these factors in a larger model. And then these are a series of questionnaires. So we include the eye track or the vestibular screening assessment, also neurocognitive testing, a series of other lifestyle questionnaires. Anxiety is something we had seen from our prior work affecting some of our measures, so we'll incorporate these metrics into it as well. And lastly, as my final slide, this is really aimed at a larger goal of developing new measures and tools that could be helpful for many clinicians that don't have access to equipment or even facilities, so that effectively provide a high-value care for many of their patients. There's a general funding approach for this, and much of this work that I'd like to do would hopefully be of interest for many faculty members that we have here at the Miami Project and elsewhere throughout University of Miami. I thank all of you for taking the time to have this discussion with me, and I really appreciate any other discussion items, and thank you as well for the introduction. I really appreciated that as well. Yes.
Like, how long after the last received or reported injury do your participants take the exit protocol?
Yeah, excellent question. So when we were doing that initial study, for some of the initial work I was doing, we had inclusion criteria for those individuals not having a concussion within 12 months to be a part of that aspect of the study. For the individuals that were completing exit, for the overall sample, we had about maybe 60 patients complete this exertion test. It was anywhere between about 10 days to 45 days post-injury. Each of those individuals, though, they would take it depending on whenever they were returning back to sport from their concussion. About 80%, 85% of concussions would then have a typical recovery within the first 30 days. Some folks say, yeah, 80% of them recover within the first 14 days. Not necessarily the case. Really, the mark that most people are accepting is around the 30-day mark, and you don't want to have a too presumptuous descriptions for patients. If you say you're going to be better in 10 days, that sort of dialogue is not necessarily best practice. And what we do find from the research is that most patients are returning back to sport roughly around the 30-day timeline. And so for us to be inclusive of, for that particular study, of individuals that are within 60 days, then we feel like they're representative of most folks post-concussion. Yes.
How does one recover if you've had 2 or maybe 3 concussions? Are there differences?
Yeah, excellent point. I can speak to what I'm aware of as well, and I think Dr. Hotz, you might have some input. I was familiar with some of the recent work at University of Pittsburgh Medical Center where they actually had clinical data where they're able to then pull out retrospective, but analyzing all of their patients that come in through their clinics. And they were able to then compare the clinical presentation, including symptoms, and importantly for your question, duration of clinical recovery for those that had 1 to 2, and then maybe those that had like 3 or 4 or more. And there are some suggested differences as you get beyond 3 and beyond 4 to 5. However, one thing I do want to acknowledge is that there is also this inherent bias that we also have for our management practices that we do have for a patient that we typically are informed of, hey, this person has had 6. Immediately, many clinicians would want to impose a more conservative treatment. And so that's something that has been a discussion point broadly, but when you account for all of those other factors, it's fairly interesting to see that there's some overlap.
For the last 12 years, high school, that's our sweet spot.
250
had more than one concussion. So they've come to us in the 12 years with more than one concussion. When you talk to those 95 kids, they've had 3 or 4. So like when I read my note, because I just pulled the 95, and I talk to the kid, some of these kids have, this is their 4th, this is their 5th, first time they came to us, right? So this whole repeated concussion, there's not a lot out there. There's not a lot of data in the real world. And what we see in live real is that we always tell kids, if you have one, you're at higher risk to have another. Okay, so that's always been, you know, what you say, that it's family and the kids. But in reality, I know cases like that, I've done this for like, 25 years, that when these kids come in and it's their 2nd or 3rd, they know that they've had the concussion now because they know the symptoms, this is their 2nd or 3rd. And they say to us, my headaches are worse. I have to read stuff over 2 or 3 times. The symptoms are more severe in real world.
Is there a guideline, if, a suggestion, if you had, say, 4, that you should really consider stopping the sport?
Well, Dr. Hodgkin's rule is, if you have more than 3, you put it on a schedule and say, well, it took me 3 weeks to get better from this one. This one was a loss of consciousness. It took me a month to get better from this one. And like by the time they've had 3 and they're bad ones, you're telling them, listen, find another sport, do something else. But we've also had kids that have had 3 that are 3 years apart that they got better in a week, right? So it all depends on like how severe. We look at the severity of these injuries. There's no golden rule like you had 3, you're out, sort of thing. It's interesting. It's really, this repeated stuff is really interesting. We need better measures.
One thing I do want to comment on is that, so there's a CARE study that the consortium that we were involved in, because Miami was involved in that same project, large effort as well, comparing the re-injury occurrence from that CARE consortium was a fairly low number. And I think one thing that has been acknowledged is that perhaps within that stepwise return to sport progression, there's just a couple of days of being symptom-free that might have a lot of value for it. Whereas the original NCAA study with Dr. Guskowitz and Dr. McRae and other large names in the field have done, that was 2001 to 2005-ish. And there was a high number of individuals that had repeat concussions in the same season. And many things have changed. And that was even before the 2008 guidelines. But then one thing that we have seen too is that since 2008, our interventions and our evaluation approaches to concussion are much more advanced than what they were back in 2008. So there has been some improvements with, like I said, this protocol, in that compared to 2004, 2005, where the likelihood of sustaining a repeat concussion, the same injury, was much higher and they had a worse outcome, we do find that the likelihood of re-injury is much lower. However, there are some other challenges that we do find within the return to sport progression that need to be improved on. Yeah, good question. Yes.
Dynamic exercise trigger many of the vestibular or like related symptoms. Do you see that? Have you compared it to like other clinical functional tests like CVAM or VOR? Would these tests be able to detect it also, or just only you can only see it with exit and great exertion?
Yeah, excellent. What I would envision is that exit is something that'd be generalizable, so that many clinics that don't have that type of access to other pieces of equipment, they can then use it as part of another tool in their toolbox. What I would envision for some of the work that I'd like to do here to better validate exit is to incorporate some of those other measures. Interest in looking at eye tracking, vestibular tracking, and one thing that we were doing at Pittsburgh for the dissertation work is that for that data collection for that study, we actually had IMUs that were going to be strapped to the forehead and also the chest. And we could then look at like synchronized or maybe more rigid head-body movements that might be more of a signature for how individuals with a vestibular impairment might do that type of task. And so we have that data from like the all 28 healthies, but the next go right is like, how do patients respond to that? And so those sort of studies are kind of enveloped within the larger clinical question, I think that's been the main driver for some of this research, is how that might align within a clinical profiles approach for then many clinicians that make those decisions. So symptoms, vestibulocular functioning, those are all a part of it. But so the measures that you've also described, I would like to do projects where we use those other outcomes to then better buttress or support and identify ways that we might be able to modify exit so that it's more applicable to other individuals. Yeah.
Many of us are interested in type of physiology and concussion and some mechanisms that can target very We have two hypotheses. One that essentially the brain during that kind of concussion, probably several papers on that, showing that you're outside exercising, you're letting yourself in those areas, sports, your brain temperature might actually be a half degree above, and you've shown experimentally that works.
Thank you very much. I sincerely appreciate that. Yes, certainly. Yeah, one more behind you. Yeah. Interesting question, and I haven't thought about it extensively to the nature that it's commonly a big part of discussion for other balance measures that might have been suggested to be used as maybe a sideline evaluation tool, where we typically had seen maybe someone's evaluated for a concussion on the sideline, and you have that brief 5 minute, and can you do a series of balance assessments? We certainly know that auditory cues and things might affect the performance on that. In the context of what we have for exit, we haven't primarily tried to use it for like distractions for sound. I think as far as like it comes to communication for our individuals, that's actually a big part of how we're trying to then better standardize the implementation of exit. What types of feedback we're trying to provide our individuals to then ensure that it's going to be representative for all individuals that will be completing exit. That's a big part of exercise science. You know, if you're trying to ask for individuals to do a max test, how much feedback and the type of feedback you provided them is real important. And so we're trying to structure it more to that aspect of the auditory input. A reflection, though, from University of Pittsburgh Medical Center, when it comes to symptoms post-concussion, including loud noises, photosensitivity, and things like that, they don't have curtains in their clinic. They actually have a. That's the second time I've done that. I apologize. They have a very busy clinic, and so their downstairs orthopedic clinic office, that's where they have all these patients do their dynamic exertion therapy. It's an intended provocation that they try to do with their patients. And from day one, it's very much of an education of, hey, let's control these lifestyle factors. You should sleep well. You shouldn't be waking up every single night for, every so often. You should also get on a good diet. You should also, maintain good lifestyle habits. And so as a part of that same discussion, patients are informed that these impairments, they are normal from their concussion, and it's a part of an expose, recover approach. That it's important to then stress some of these subsystems that might be affected by concussion, to then use that to then engage their ability to then return back to their sport. So even when patients are doing vestibular therapy, they're going down a busy hallway and corridors, they're trying to then give patients the education to then also understand that sometimes these symptoms might be provoked and it's normal, and understanding that they will subside, and it's a part of their progressive return back to their pre-injury levels.